Today my topic is antithrombotic therapy in high bleeding risk patients who have undergone percutaneous cardiac interventions like angioplasties or any. Yes, sir.
Okay.
So, like patients who have undergone percutaneous cardiac interventions who needs dual antiplatelet therapies, and for patients who are high bleeding risk patients. These are the patients, like how to deal with these patients who have high bleeding risk, how much dual antiplatelet we should continue, and if the patient requires oral anticoagulant also because of indications commonly like with atrial fibrillation. So how long we should continue, whether we should continue with the dual therapy or with the single therapy, or how to add with the oral anticoagulants along with that. So this is the article came in Journal of American College of Cardiology 2024. So to start with, antithrombotic therapy after percutaneous cardiac intervention is the key for the prevention of thrombotic events after angioplasty to prevent the stent thrombosis. And bleeding in these patients is directly proportional to the number of antiplatelets along with anticoagulants, duration of antiplatelets, potency of antithrombotic agents which are used. So, bleeding complications have important clinical implications. So, identification of the patients with high bleeding risk, that is very important. Modulation of antithrombotic therapy, if we found that patient is a high bleeding risk, then how to modulate the antithrombotic therapy. And there should be a balance between the safety as well as the efficacy of antithrombotic agents, so that our purpose of giving dual antiplatelet or oral anticoagulant should be adequately achieved. And in the same way, the patient also should not develop any bleeding complications. And if we found that yes, the patient is with high bleeding risk, then how to de-escalate the antithrombotic medicines, that is also very much required to reduce the bleeding chances without compromising the efficacy of the antithrombotic agents. So antithrombotic therapy reduces the risk of stent thrombosis, most commonly in the coronary angioplasty patients after that. So before endothelialization, the chances of stent thrombosis is very high. So initial first 3 to 6 months of dual antiplatelet therapy is very much required. And if the patient is on high bleeding risk category, so gradually will reduce the medicines that I will cover later. So dual antiplatelet therapy is indicated in patients after angioplasties, after patients who have undergone for transcatheter aortic valve implantation, transcatheter mitral valve implantation, or any patients who have undergone left atrial appendage closure also, patients who are having a chronic AF and who are at high risk of giving chronic oral anticoagulants. So these are the patients we recommend left atrial appendage closure. So dual antiplatelet therapy is associated with high bleeding risk. High bleeding risk groups are susceptible to adverse outcome. Percutaneous cardiac interventions, either coronary or structural, are often performed in patients with high surgical risk. Usually they have multiple comorbidities, especially in patients who are undergoing TAVI. With reduced thrombogenicity in coronary stent platform is also one of the method, one of the technology we can use so that the dual antiplatelet therapies we can reduce. So bleeding risk in patients who are undergoing PCI risk is proportional directly to the intensity, duration, and the number of antithrombotic agents given. Adding clopidogrel, prasugrel, or ticagrelor to aspirin decreases the rate of stent thrombosis and ischemic event, but it increased the risk of major bleeding. So the longer the duration of dual antiplatelet, more the risk of bleeding in patients who are on dual antiplatelet. And dual antiplatelet therapy along with oral anticoagulants, if patient who have undergone percutaneous cardiac intervention, they have definitely very highest bleeding risk if we give dual antiplatelet along with oral anticoagulant therapy.
Is there any head-to-head trial, aspirin, clopidogrel, aspirin, prasugrel,
Yes,
aspirin, ticagrelor?
yes, I am coming there. So how to calculate the score in patients who are at high bleeding risk? So there are two commonly used score. One is predict DAPT score and one is ARC high bleeding risk score. In this predict DAPT score, there are the different parameters they have taken, whether the patient is having any renal dysfunction, liver dysfunction, any prior history of bleeding, stroke, and patients with age more than 70 years. There are different major and minor criteria have been taken. So I am coming to that. And this is a trial, antithrombotic trial, in which the master DAPT trial one is in which they have used the absorbable stent in which it gets absorbed over a period of time. So the patients have been given 1 month and 3 months of dual antiplatelet therapy, and they have found definitely the chances of major bleeding is less in patients if they are given 1 month of dual antiplatelet therapy comparing with the 3 months of dual antiplatelet therapy. And there are other different trials where the dual antiplatelet therapy is given, and where the comparison of dual antiplatelet was given by whether with the 6 months versus 12 months of dual antiplatelet therapy, and it was found there was no much major difference in the major bleeding, especially with this was master DAPT trial, 1 month versus 3 months of dual antiplatelet therapy. There is definitely a major bleeding chances was found to be less if we are given only 1 month of dual antiplatelet therapy. These are the different trials with the de-escalation strategies in patients with a high bleeding risk, where we have given 3 months to 12 months comparison given with the dual antiplatelet therapy, and there was not much of difference found in these trials. And coming to another trial where there is an aspirin-free strategy, where the aspirin was stopped, only either ticagrelor or monotherapy was given for 23 months, versus the patients who are given on dual antiplatelet, and there was found there was no major bleeding risk. But this trial where ticagrelor monotherapy and dual antiplatelet was given, there was definitely found to be there is a reduced chance of bleeding. And another trials also they have found that with monotherapy and or with a aspirin-free strategy, where we are given only, where the trial people have given only clopidogrel monotherapy or ticagrelor monotherapy, there is a chance of reduce in the major bleeding. So this is also, there are many trials where they have found that monotherapy is also equally beneficial, and the chances of reduction of major bleeding was found in these patients. So coming to the antithrombotic strategies after PCI patients who are high bleeding risk, patients without oral anticoagulation requirement. In these patients, either we can shorten the duration of dual antiplatelet medication or lowering the doses of drugs. Prasugrel we can reduce from 10 mg to 5 mg. We can reduce ticagrelor also from master limited trial which I told, the shorter 1 month of dual antiplatelet therapy followed by monotherapy. And in patients with genetic testing, we should see whether there is a gene coding of cytochrome P450. This is the main enzyme which converts the clopidogrel into active metabolite. So by genetic testing, we can found that the patient is clopidogrel resistant or not. After this only we can start with the clopidogrel monotherapy if there is no resistance to clopidogrel. So this is another different trials where this one patients with an indication of oral anticoagulant requirement. In this dual anticoagulants like clopidogrel along with rivaroxaban was given in these patients where their oral anticoagulant was required. So there was no difference in the versus aspirin clopidogrel combination along with clopidogrel plus rivaroxaban. So different head-to-head trial, these different trials were done and there was no major difference in chances of bleeding. But one trial with clopidogrel with apixaban found to be superior for clinical relevance, and there is a chances of reduce in the bleeding chances if we given clopidogrel plus apixaban and without aspirin. So patients with an indication for oral anticoagulant requirement after PCN, if atrial fibrillation is the most common indication where we have to give oral anticoagulant along with the dual antiplatelet therapy. So it will be a triple antithrombotic therapy where a combination of either clopidogrel, aspirin, along with that we have to give oral anticoagulant like dabigatran, apixaban, rivaroxaban or warfarin. So it's a triple antithrombotic therapy where the chances of bleeding is very high. So if patient with the high bleeding risk, we can either reduce the duration of this triple antiplatelet therapy or we can increase the duration of dual antithrombotic agent for a longer time. So patients who are undergoing the coronary graft angioplasty stenting, these are the patients requirement these are the patients who require dual antiplatelet for 3 months or single antiplatelet therapy for longer duration. These are usually old age patients who are undergoing post CABG angioplasties and where dual antiplatelet is required. Otherwise, there will be a high chance of stent thrombosis, and there is with the old age and other multiple comorbidities, chances of bleeding is also very high. So in these patients, we should be very careful. So this is the approach like patients with antithrombotic treatment, how we should give in the patients who have undergone coronary stenting. So initially, the two major the scores like precise DMT score, if the score is more than 25 or ARC HPS where there is one major criteria or two minor criteria. If these patients, these are high bleeding risk group patients, if there is no requirement of oral anticoagulant, we should give dual therapy for first 1 to 3 months, and after 3 months of dual antiplatelet, we can keep the patient on aspirin alone, that will be sufficient after angioplasty. And in patients who needs oral anticoagulant, we should give first 7 days triple antithrombotic therapy. After 7 days, we switch over to dual antithrombotic agent. That can be one of either ticagrelor or we can give along with that one oral anticoagulant. After 6 months of this dual antithrombotic agents, we can put only on oral anticoagulant alone in after angioplasty. And coming to another aortic wall replacement, another that I will cover later. So in bleeding risk in patients who are undergoing transcatheter aortic wall replacement, these patients are usually who are not fit for surgical, who are not surgical candidates and who have many comorbidities. So these are the patients who are going for aortic wall replacement, and these patients already have many comorbidity burden. With that, the chances these patients. So how to it's what are the risk factors in patients who are at high bleeding risk, patients undergoing TAVI, female patients, patients with chronic kidney disease, older age patients, patients who have concomitant atrial fibrillation along that, or patients who have prior history of bleeding. So in these patients, we should give dual antiplatelet therapy for 3 to 6 months, or we can, after 6 months, we put the patient on single antiplatelet therapy. And oral anticoagulant is to be given only if it is indicated or very much required, then only we should give this patient oral anticoagulant. Otherwise, DABT for first 3 months, 6 months, and after that single antiplatelet therapy. Patients who are undergoing trans-aortic replacement. So this is the another. There are the different trials where the transcatheter aortic valve replacement was done, and the patient was not requiring oral anticoagulant. So these are the different trials they have conducted where the aspirin alone was given versus the 3 months of dual antiplatelet therapy. So the first trial there was no major difference, but second trial definitely there is reduced vascular complications, reduced chances of threatened bleeding, where the aspirin alone was given versus 3 months of dual antiplatelet. So with the dual antiplatelet, definitely the chances of bleeding is very high in patients who have undergone transcatheter aortic valve replacement, and patients who needs indication for oral anticoagulant. In this patient, oral anticoagulant alone or clopidogrel for 3 months was given. So coming to another percutaneous cardiac intervention, that is left atrial appendage closure. That is required in patients with non-valvular AF patients, and 80% of left atrial appendage closure was done patients with high bleeding risk who cannot give the patients for prolonged oral anticoagulant with advanced age, multiple comorbidities, renal dysfunction, prior stroke. These are the patients who are the candidates for left atrial appendage closure. So after, what are the antithrombotic strategy in these patients? Vitamin K antagonist plus aspirin we can give along with that apixaban, rivaroxaban or dual antiplatelet therapy. And after a period of short time, we can switch over to single antiplatelet therapy. So this is the left atrial appendage closure patients where the oral anticoagulant therapy versus the dual antiplatelet therapy comparison was done. And in one trial they found there was no major difference, but in another trial they have found the major bleeding chances was very low, and with patients who are given full dose of dual oral anticoagulant plus aspirin, and in patients who are given aspirin alone with oral anticoagulant. So another patients with percutaneous mitral valve interventions. In these patients also dual antiplatelet, vitamin K antagonist, rivaroxaban. These are the choice of medicines to be given after mitral valve intervention. So the approach with the patient with aortic valve replacement with left atrial appendage, the scoring with a high bleeding risk criteria to be made up. So a patient with aortic valve replacement with no oral anticoagulant requirement, with aspirin alone will work. And if there is a requirement of oral anticoagulant after TAVI, oral anticoagulant alone is sufficient to prevent the bleeding in the patient. And patients with left atrial appendage occlusion also, either aspirin alone or oral anticoagulant alone will be sufficient for this after the intervention to prevent the chances of bleeding. Same with the mitral and tricuspid valve interventions also. If the patient comes in high bleeding risk criteria, and either aspirin alone or one of the oral anticoagulant alone, that will be sufficient for these patients to prevent the major bleeding. So coming to the conclusion, there are growing number of patients undergoing cardiac percutaneous interventions, either angioplasties or TAVI or other procedures. they are at very high bleeding risk. Identification of these patients with high bleeding risk is important. Implementation of antithrombotic treatment is required, and balance between the bleeding and the thrombotic risk to be managed, and there are more dedicated trials are required for particular antithrombotic medicines so that we can come to certain guidelines. There are no specific guidelines for this. So in this trial they try to cover like how we can approach a patient with a high bleeding risk and what we can do after 1 or 3 months of dual integrated therapy. Just putting on aspirin alone, otherwise the chances of bleeding will be very high.
So here there are 3 questions. One,
Yes.
first question is aspirin with ticagrelor, prasugrelor and clopidogrel.
Yes.
Say aspirin with these 3 combinations,
Yes.
which is giving more bleeding.
So
With 2 combination gives more bleeding.
so prasugrel is
Prasugrel again more than 70 years.
yes, more than 60 years.
More than
Prasugrel is what we found as from.
and this knock we are giving.
Yes.
Okay. Out of 4, which is more comorbidities friendly and drug interaction friendly. See, renal failure, obvious choice is epixaban. When it comes to renal failure, obvious choice is epixaban. Now see, when it comes to anti-epileptic drugs is concerned, see, levetiracetam is very drug interaction friendly and very less side effect profile. So that is how, as a general physician, if any patient with comorbid condition comes, it is a blind procedure to give levetiracetam. So that's how I ask the out of 40, either we give lot, we come across most of the patients who are having comorbidity.
Yes.
Maybe COPD, may taking through 3-4 anti-diabetic drugs, anti-rheumatic drugs, and so forth. So many drugs people are taking. So do you have any out of 4 now, which is drug interaction wise friendly?